Okay, so you're called upon to see this patient who was brought on a stretcher. Spine precautions were maintained. He's in a rigid collar, and you want to make an assessment. So in the trauma bay, usually the trauma surgeon and or residents are there waiting for the patient to make an assessment on the ABCs, airway, breathing, circulation. Before you start delving into the injury and finding where the injury is and how to fix it, you want to make sure that the patient is not suffering from a life-threatening condition, an internal bleed, or the patient is choking because of an obstructive airway. So you check that primary survey first. How do we do that? So we make an assessment on the vitals, and let's look at the vitals. The blood pressure was 118/72, heart rate 90, respiratory rate 22. He was saturating 98% on room air. Quickly, does these numbers look okay to you?
So there's an increased respiratory rate.
It's a big increase, commensurate with pain, but is the patient, otherwise the patient's vitals are stable, right? So we're happy with that. A quick blood draw shows that the hemoglobin hematocrit 1442, white count 9,000, chemistry normal. Does that look okay?
There might be some kind of hemoconcentration, or is it?
That's within normal ranges. So usually what we're looking for here is like a drop in hematocrit hemoglobin, like 7, that would make you concerned about like an active bleed. And that was not the case. So far, the ABCs are checking out. The trauma team completed their primary survey with no intervention. So always think when you see a patient with polytrauma, ABCs first, before you go into, our role comes into assessing the patient's neurological condition and mental status. So with a neurological exam, which comprises the disability component of the primary survey. So this is the patient's neurological exam. The patient was awake, oriented to time, person, and place. His cranial nerves 2 through 12 were normal. His motor power showed the following. His deltoids were 5 out of 5, biceps 5 out of 5, triceps 2 out of 5, and his hand intrinsics were 0, and his lower extremity exam was 0. So it's a drastic exam. So he could not move his hand intrinsics, and his lower extremities had some weakness in the biceps and the triceps. His sensory exam 2 showed a sensory level at about C7. So he could sense his shoulder, proximal arm, a bit of his distal forearm, as well as the thumb and index fingers, but nothing else. So that would put him at the sensory level of C7. He was hyporeflexic in the upper and lower extremities. So a neurological exam is important. Why? Because it would localize the lesion. So a history is important, but a neurological exam is important in localizing the lesion, which is the cornerstone of neurology, neurosurgery, and neurosciences, is to localize the lesion. Where should we image? Where is the deficit? In the neuro axis, brain, cervical, thoracic, lumbar, peripheral nerve. Where is the deficit in that neural axis? So where do you guys think the lesion is? Is it in the brain, brainstem, cervical spine, thoracic, or lumbar, based on this exam?
Probably cervical spine.
Excellent. It's in the cervical spine. The patient has upper and lower extremity weakness. So it should locate somewhere in the cervical spine. Let's say, added to that, the patient had absent gag cough, and he had an issue with his oculomotor power, or loss of facial sensation. Where would you localize the lesion?
Brainstem.
Brainstem. Excellent. Good job. So this lesion localized to the cervical spine, and hence we want to image the cervical spine. Now, in a patient with polytrauma, second nature, usually a patient with polytrauma, suspected cervical or brain injury, they automatically get a head CT. So here we're localizing the lesion to the cervical spine. What imaging we want to order?
I have a quick question.
Sure.
When you said there's numbness, is it like both sides numb to pinprick, or it's one side?
Yeah, both sides.
Okay.
Both sides symmetrically, perfectly symmetrically. Yep.
Thank you.
Sure. So localize the lesion. What imaging do you want to order? We got We got a head CT, obviously, with any polytrauma case, but more importantly, a CT of the cervical spine, which is the gold standard. Why is the CT a gold standard and not an X-ray? Let's say can we get an X-ray of the cervical spine, AP, lateral, obliques, open mouth? You know, is that adequate? The answer is no. Why is that? Because an X-ray of the cervical spine would miss lower cervical injuries and upper cervical injuries. For example, if a patient has a fracture involving the occipital condyles, this may be missed on an X-ray. More importantly, if a patient has OC dissociation, where the bones are normal, but the occiput is displaced or dissociated from the cervical spine from C1, then that can be missed. And missing that is a disaster, because these patients, if they're intact, any movement would cause them to become quadriplegic because of the inherent significant instability of this injury. Also, we may miss an injury involving the lower cervical spine or upper thoracic spine with an X-ray, because the shoulders are in the way. Okay, so we got a CT of the cervical spine. Now, oftentimes patients with, let's say, a cervical spine fracture may have another fracture elsewhere in the spine, but they're not paying attention to it because of the significant pain and morbidity because of the index injury. They may not report thoracic or lumbar area pain, and hence we still image them because we want to rule out concurrent injuries. We do that either with thoracic or lumbar X-ray, or we get a CT of the chest and pelvis, which is usually part of the trauma protocol. So already, when you see those patients that already have a CT of the chest and pelvis, which can image and includes imaging of the thoracic and lumbar spine. Okay, let's look at the cervical spine CT. And who wants to take a crack at this?
Looks like a dislocation of C6.
Good. So let's look at this. So this is a mid-sagittal view. These are parasagittal views. And excellent. The first thing you look at is the spinal alignment. And look at the spinolaminar line here. You look at this here. It's really good and smooth. And then it gets disrupted here. And you can see here, there's a dislocation or malalignment. Looking at the parasagittals at C2, 3, 4, 5, you can see here how the facets are well aligned here. See 3 over 4, 4 over 5, but then you can see that this facet is displaced over this one, C5 over C6 on both sides. So we call this bilateral jumped facets. And that's how it looks like on the axial view. Bilateral jumped facets or a fracture dislocation is the diagnosis. Does this image explain the patient's symptoms?
I have another question, if you don't mind.
Sure.
Why is it dislocation and not subluxation?
It's the same. Fracture subluxation or fracture dislocation.
Okay, thank you.
Semantics. Yeah, sure. We usually say fracture dislocation more commonly. I mean, so
it does.
It does, correct. So yeah, there's definitely a significant injury and explains the patient's Asia A injury, complete spinal cord injury at C7 or C8. So this is a fracture dislocation. Now we're going to digress here for a moment to speak about a very important principle. When you see a patient with a spinal fracture, we need to make an assessment as to whether the fracture is stable, which means it may heal with a neck collar, rigid collar bracing, or a crown halo vest bracing, or an unstable fracture that would need internal fixation and stabilization. And this is an important distinction. That's where our role comes into play, assessing patients' spinal stability. Why is that? Because if you treat a patient with an unstable spine without an operation, you treat them with neck collar bracing or with a crown halo vest, their neurological insult will cause worsening deficit, disability, deformity, and the fracture won't heal. So that's why you don't want to miss on an unstable injury. And there are ways that help us guide make that assessment accurately.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.